We'll be starting our simulation mock exam now. I will be the teacher and Dr. Hariharan will be the student. We'll be moving on to the mock exam now. So initially they'll be giving you a case like this. 60-year-old male patient, known diabetic for 20 years. He presented with a history of decreased sensorium from past 2 days. He also complains of loin pain and burning micturition in the last week. Upon arrival to the hospital, he was lethargic and disoriented. His vitals were temperature 101.3 degree Fahrenheit, BP 160/90, heart rate was 120, respiratory rate of 30, saturation of 96% on room air. On examination, he had dry skin and mucous membranes were noted. Initial blood sugars were 800 mg per deciliter. So, Dr. Hariharan, can you read the vignette and the questions and answer these?
Yes, ma'am. He's a 60 years old male who's diabetes for past 2 days. He's unwell, lethargic, having a fever, loin pain, and burning micturition. He came to hospital with fever, tachycardia, along with he's having high sugars. So, what are the differential diagnoses? So, 60 years male with loin and burning micturition, probably in high chances for urinary tract infection. And being a diabetes, the risk is always high. And the sugars of around 800, you may be having a DKA or HSS with urinary tract infection.
Any other differential diagnosis you would like to tell? Okay, how will you further investigate to prove your diagnosis?
Check out ABC of the patient. If it is fine, then I'll ask them to go cultures, or give a broad spectrum antibiotics, start him on IV fluids.
Can we stick to the question? How will you further investigate to prove your diagnosis?
I'll do an ABG to see his acidotic pattern. Then I'll send serum ketones or urinary ketones, and I'll take an ultrasound or CT-KUB to look for any urinary tract obstruction.
Okay. Anything else you will want to see from your differential diagnosis? You were telling 2 or 3 differential diagnoses, right? Do you want to do anything else to prove your diagnosis?
This is only I do, ma'am.
What is the role of ABG in this patient? Why do you want to do an ABG?
ABG,
Okay. What will be your initial line of management in this patient? Yes. What
can you
will
able
be
to hear me
your
now?
line of management?
We'll start him on IV fluids. If there's a DK or HSS, he'll be like fluid depleted. So he'll be like close to around 5 liters depleted. So I'll give him a
Okay. What will be your treatment endpoints? Do you want to answer or do you want to go to the next question? Dr. Hariharan, we are not able to hear your voice. Can you reconnect?
Sorry. Apologies. Sorry. I got a call from a neurologist. Sorry.
Okay.
Yeah, sorry. Where were he? We will be like initial line of management, right?
Yes.
Being a DKA HSS, he'll be like fluid depleted, so we have to give him close to around 5 liters per day. So I'll start him on around 1 liter of IV fluid bolus, and followed by I'll start him on infusion around close to around 100 to 150 ml per hour. Meanwhile, I'll collect my ABGs to check out if potassium is more than 3.5. I'll start him on IV insulin. If potassium is low, I'll correct the potassium. Then I'll start him on IV insulin. Then, being a neurosepsis, I'll send cultures, urine cultures, blood cultures, and I'll start him on broad spectrum antibiotics.
What will be your treatment endpoints?
So, treatment endpoints for DKA HSS, I'll have to wait for the anion gap to close. At least 2 anion gaps gets closed. Then I'll switch over to subcutaneous insulin. And once he became awake and obeying commands, because being lethargic, then I'll start him on oral diet. And I look into ultrasound or CT, look for any obstructive features is there, then I'll get an opinion to get clear it off. Urology opinion.
Fine. We will stop here with the first vignette. Dr. Alisha, do you want to give your viewpoints? Dr. Alisha, are you there? Fine. We'll wait. We will just go ahead. See, as all of you noticed, there were 5. There'll be each vignette which will have 4 or 5 questions. In each vignette, you need to answer to the point. You cannot beat around the bush because the examiner will not give you so much of time for you to answer. You need to keep moving on to your next question so that the number of vignettes you move, the amount of score you will be scoring at the end of each vignette. So if you ask for your differential diagnosis, you need to tell which is the first priority. Like you can tell urosepsis, DK. When they ask how will you further investigate this diagnosis, you should not tell shall I tell, maybe. Those words should not be used during your exam. When they ask you how will you further investigate to prove your diagnosis, you need to tell only regarding the investigations. So if your first differential diagnosis is going to be urosepsis, you really need to start with tell I will send a CBC. There I will look for a total count. There'll be each investigation you ask for, you need to tell them why you're sending that investigation. You cannot blanketly tell that I will send CBC, RFT, LFT, cultures, procalcitonin. You cannot keep telling all the investigations to them. So you need to tell regarding this particular case, which investigation is required and what will be your diagnosis. And when they ask you specific questions like what is the role of ABG, you need to tell, yes, I would like to do an ABG because in ABG, I would like to look for the acidosis and I would like to look for the pH, lactates and everything. So I would require an ABG. The next question was, what will be your initial line of management? So in your initial line of management, you need to talk about fluid resuscitation. So when you're talking about fluid resuscitation, you need to tell about the type of fluid you're going to use, how much ml, like you're going to give bolus or you're going to give maintenance fluids, and why are you choosing a crystalloid or are you going to choose a colloid? You need to tell it in whole detail and not in tits and bits. And when they ask about your treatment endpoints like DK, what will be your treatment endpoint? You need to specify that, yes, I would like to look for an ABG to see if your acidosis is corrected. I would like to look at the anion. I would like to look at the serum ketones. You need to be very precise in answering your each vignette. Any questions on this or shall we move on to the second vignette? Can anybody unmute yourself an answer, or can we? I'll be moving on to the second Vignette.
Excuse me, ma'am. I would like to know
Yes.
that we have to answer differential diagnosis in the first term, and subsequently we have to answer for the investigation. So do we
Yes.
need to include all the investigation for all the differential diagnosis which I have?
No, you will be like your priority differential. Like you can tell this patient had urosepsis with an underlying DKA. So
Okay.
only for that you can tell them, for this I would like to tell, this is the further investigations I would like to prove your diagnosis.
I can skip the differential diagnosis of honk that we should
Yes,
be
yes,
primarily focusing on DK only.
yes. DKA and urosepsis you have to tell.
Okay, okay, ma'am. Thank you.
Yeah.
One more, Rachit. When you're saying about your diagnosis, you should be pretty sure that you're able to explain your diagnosis. If you're not sure about any diagnosis, please don't utter them. Even if it is not able to make multiple diagnoses, you no need to give around 5 to 6 differential diagnoses. Maybe 2 is more than enough. So you should be very precise and very clear about what you're going to say, right? And if you're able to tell them also how you're going to investigate also. Because if you're telling a diagnosis and you're not able to give an investigation, that is also becoming difficult for you. Then you'll get more nervous.
Any other questions? Basically, you people need to see how we are answering and what are the questions, because it will be mostly these similar questions which will be coming in the exam for each case. And if you have any doubts, you can clear it now, because next we'll be directly after this mock simulation, we'll be moving on to the direct mock exams. Okay, if there are no further questions, we'll be moving on to the second Vignette. Dr. Hariharan, can you read the second Vignette?
Patient was diagnosed with HHS, treated with fluids, naive insulins, urine pustles were 100. Cultures were sent and he was initiated on broad spectrum antibiotics. Patient went on to require single vasopressor support at low dose, 0.02 mics per kg per minute, USG abdomen done. You're showing the left kidney.
So these are your questions of the second Vignette. So here I've given you all these questions, but usually in the exam, it will be like first question, then your second question will be asked, and then your third question. So all the questions will not be shown at the same sitting. So yes, you can proceed, Dr. Hariharan.
How will you define septic shock? Septic shock is defined as a patient who is in sepsis after giving adequate fluid resuscitation, is not able to require MAP more than 65, requiring an vast pressures to maintain a MAP 65.
What will be your choice of antibiotics here?
We would like to start him on a broad spectrum antibiotic, probably with ESBL coverage. I'll go with third generation cephalosporins, but being in shock, I'll prefer to go in with the carbapenems. I'll start him on meropenem 1 gram IV.
What kind of antimicrobial microbial coverage you are aiming at in this patient?
Being an urinary tract infection, I'll be looking into cover mostly about the gram-negative organisms. It will be in either extended spectrum beta-lactamase, Klebsiella, E. coli.
What are the measures to control sepsis in this patient?
In this patient, we done a ultrasound abdomen showing a left kidney. Left kidney is dilated, which is showing an HUN. I'll get an urologist opinion, and then I will take him for DJ stenting to drain the infected urine. And if there is any calculi, I'll try. We'll
What is
proceeding
the
with
role
later.
of metabolic resuscitation in sepsis?
Sorry, ma'am, I don't know.
Okay. So this is the end of Vignette 2. So here you can see how do you define septic shock. So when they ask definitions, you need to answer how is it in the book. Like sepsis, 3 definition has to be told. And you can see this is in purpose. We didn't tell the answer properly because I was trying to explain. So you should not tell it in tits and bits. You need to answer how is it. Like I would like septic shock is defined as life-threatening organ dysfunction, like that. When you tell, you need to tell how much vasopressor requirement and how much is the lactate levels, and after adequate fluid resuscitation. So all these 3 points have to be mentioned when you define septic shock. And when you mention about your choice of antibiotics, please keep in mind, no using brand names like I would like to tell Meronem, Meroplan, or if you're going to tell about BLBLI, you cannot tell I'm going to use like Ecobag DS, all this. You need to tell which class it belongs to and what is the dose. If you have weight based, you need to tell weight based. If there is not weight based, then you can tell the dose of antibiotics. And make sure you should tell whether it is IV, IM, you're going to give us a bolus or you're going to give us an infusion. All these has to be mentioned when you tell what will be your choice of antibiotics. Next, moving on to what kind of microbial coverage in specific to your patient, you need to tell. Like in case it's a neurosepsis, you should tell more probably will be gram-negative organisms. So I'm thinking in terms of E. coli. Mostly in this, we'll have ESBL E. coli. So you need to complete your sentences. What are the measures to control sepsis in the region? Make sure that you tell, I will get an ultrasound or a CT KUB done. I will get a urologist opinion and will plan for degestenting. All these has to be mentioned. In any case scenario, when they tell what are the next procedures, if there is a surgeon to be involved, make sure you tell, I will involve the surgeon in treating this patient. The last question was, what is role of metabolic resuscitation in sepsis? So I will just leave it as an open-ended question. Here, I would like to tell what Dr. Hariharan told was right. Like he didn't know what was it and he didn't try to attempt to blabber it because you should not irritate your examiners. If you know, you have to answer. If not, you need to move on to your next question. Anybody from the attendees want to tell about what is metabolic resuscitation in sepsis?
So I'll interrupt over here. Can you tell me at least what drug do you use in case of septic shock? Intractable septic shock. At least people can answer that in the chat box. What do you use? Yes, somebody wrote hydrocort. Yes, actually use of steroids. In case of intractable septic shock, when you're asked to add steroid, that is the role of that is the metabolic resuscitation in sepsis actually. The point what Dr. Sashi told, that is what you have to remember in mind. Now, actually, Dr. Hariharan and all are reading the questions, but ideally in the exam, you will be given the case vignette in a paper. You will be asked to sit at one place and go through that vignette. And then the examiners, because now the exam is physical exam, it's no more online exam like we had. So you will be going near the examiner. 3 or 4 of them will be sitting over there and they will be asking these questions from the vignette. So the vignette will be already pre-prepared. It will be same for everyone. But they would have kept 4-5 sets of cases in which you might get 2 cases, your friend might get another 2 cases. Okay. And last time what we had put the cases and questions, 90% of that is what our students got. What is what the feedback we had got from our students also.
Anything else do you want to add regarding these questions, Dr. Alisha?
No, that's what I told. Like whatever we have covered is from our experience and what from the feedback from our students. So that's why we have put like that. So these are very direct questions. Even in an exam also, you are going to get very direct questions. All I can say is that all 3 of your vignettes may be about 3 different topics. It may not be the same thing. If it started like here, it started as a DK. And the patient now goes into sepsis. Then the patient can go into cardiac arrest or the patient goes into tracheostomy or VAP. So it can vary. So if one of the vignettes also, if you're not able to answer properly, do not get demoralized. Try to pick up with the questions and answer well in the next vignette. Most important is try to organize your answers. Don't just go randomly telling everything which comes to your mind. Stick to your differential, like how Dr. Hariharan told, urosepsis, diabetic ketoacidosis, possibility of HHS. Then what are the investigations you're going to do for that? Similarly, what Dr. Sashi told, septic shock, sepsis, septic shock, all these things, these are like what you tell, these are mark scoring definitions, right? You will easily score in them. So you should not get stuck in your stock question. Septic shock is something you will be definitely asked. If the your patient is going to the use of vasopressor, they'll ask what is a bundle, first hour bundle, what all you do, antibiotic choices. Like they've already, I think they are outlining all the issues and the points which you should be mentioning properly. But organize your answers. Take 3 seconds or 5 seconds of your time to think in your mind that if this is a question, how am I going to approach and answer this question? Just take 5 seconds of your time and then start answering. So after this simulation, actually, when we have these mock exams next two of that, where you will be facing us as your examiners, your mock examiners, then you will get an idea. When you answer, we will be there to correct you.
We'll be moving on to the third Vignette from here. In the chat box, we'll just see what question is it. Okay, no questions. So now moving on to the third Vignette. So he was taken up for DJ stenting. During the operative procedure, he went into cardiac arrest, shifted to ICU immediately post resuscitation. His GCS now is E1 VT M1, BP is 110/70 on dual vasopressors on mechanical ventilation. So Dr. Hariharan, will you be able to answer these questions? What will you counsel the family members?
Still the family members about the cardiac arrest which happened during the procedure.
Okay.
Because that was a because it was from net. Sorry. I'll counsel the family members about the cardiac arrest which happened in the hotel. Because
Okay.
this procedure has been done in the good interest of the patient to take him out of the danger, because he's already sick. Without that, the chances of survival seem to be very less. And being the cardiac arrest which happened and witnessed, and he was resuscitated and came back to the ICU, I'll explain his critical condition and what is our plan of management.
Okay. Okay. What is the role of TTM management in post-cardiac arrest care?
TTM management, based upon the recent trial TTM2, target temperature management doesn't show a much neurological outcome compared to the hypothermia versus pneumothermia. So I like to maintain the patient of temperature of around 36 degrees, and I'll avoid temperature not going more than 37.2 degrees for another 72 hours.
What are the other measures you will initiate in this patient?
Apart from TTM, madam?
Yes. Anything else you would like to do to this patient? What are the prognostic indicators of poor outcome in this patient?
The prognostic indicators of a cardiac arrest, I look for the signs of HIE, looking at his pupil, reactivity of pupil, 48 hours, CT brain.
So how will you rule out HIE bedside?
I'll stop the relaxant, assess his GCS. If he's having a response less than M5, and his pupils are not reacting at more than 48 hours, and he's throwing a status myoclonus within first 24 hours. And
any imaging you would like to do?
I would like to do for a CT brain, and look for gray matter differentiation. If it is an absent, it is poor prognostic indicator of HIV.
Okay. In case post 48 hours, this patient has no brainstem reflexes, how will you assess whether this patient can undergo brainstem death declaration?
Patient has
no brainstem
no
reflexes in the
brainstem
bedside when
reflexes.
you
Yeah. Oh,
assess.
yeah. The
So how
patient
will
is
you
having no
assess?
brainstem reflexes. I'll make sure that he is not on any sedative or relaxant for more than 6 hours. I'll look into his I look for prerequisites for making a brainstem declaration, which includes chance of irreversible damage, either confirmed by imaging, and I'll look for his temperature is normal and he's on not any sedatives or drugs. Then I'll proceed with if all these things are fine, and then I'll proceed with apnea test.
Okay. So we have come to the end of this third vignette. So here I would like to tell few points. The first one is how will you counsel the family members? In any case scenario you get, you will have a question on counseling the family members. So in this, most important to remember communication. So how you need to address yourself, whom you are and what you are, and you need to ask the other person to whom you are talking to and what did they understand about the patient till now, and from there you need to continue. You need to introduce yourself when you're counseling the family members. That is very, very important. And there is something called the spikes protocol, which you need to tell about what is spikes protocol also. What is the role of TTM management? You might not be asked about detail about the trials, but you need to read about what is TTM1, what is TTM2, at least in gist. From life in the fast lane, they'll be giving you small gist about each thing. At least go through those. And the prognostic indicators, see, you've seen in this patient was initially, we were talking about decay, urosepsis, and how in the second vignette, everything turned into septic shock, the antibiotic choice and everything. And how the third vignette is completely different from what we have spoke about in the first and second vignette. Like the third vignette is mostly about counseling, TTM, and about apnea testing. So you cannot assume that if I get a pancreatitis case, I will get questions only about pancreatitis. So you'll be getting questions about pancreatitis, then you'll be getting questions about ARDS, and the last scenario can be still the same, like patient had a cardiac arrest. What are the prognostic indicators? How will you do apnea testing? Role of CT angiography, role of MRI in these patients, and how are you going to counsel? Sometimes they can ask you questions about how are you going to counsel the family for organ donation also. So you need to read all these before you come on to your mock exam. Any questions? Dr. Alisha, would you like to add any points to this?
No, I think you have covered most of it. So the same thing, like already what I've already repeated anyways.
Okay. Dr. Hariharan, do you want to add any points to these?
Yes, yeah. We deliberately made some lot of mistakes actually, so that it should not be answered like this. Okay. Regarding counseling, it's very important. Definitely, you will get counseling. Nowadays, more importance is giving for a communication. Don't counsel like me. This is what happens when we face students in our institute also. Most of the times will be there. So, like spike protocols, all those things, don't try to remember all those things. Make sure that what the examiners think is that how will you do the counseling in real time, right? So you should know about the basic protocols, but it should be like you should go them properly, introduce them, ask them what they've understood. So what was spoken to them earlier, give them adequate time to sit, take them in a private room, explain what are the things which has been happened to them, give them time to adequately to answer to this. So what was happened there, what you are expecting. So all those things you should include it. So mainly they will look into your communications. And regarding that, I just deliberately tell the trials. If you're not able to, most of the examiners will don't look into too much into the trials, right? So don't tell trial names unnecessarily. If you know it, if you're able to tell the advantages and disadvantages, or you know something about gist of the trials, please utter the trial names. Most of the times in panic, we'll say some trial name. Ultimately, I say TTM2, then I'll next question will be like, what is TTM? Then they will ask, what is TTM1? How will you differentiate and all those things? So it will be there. So don't turn all those things because it doesn't know that what is the role of TTM management. You stick to it. What are the temperature you're going to achieve, how long you're going to achieve, how you are going to achieve. That is more than enough for this question.
We have two more. I would like to invite Dr. Ankit to give his valuable points here.
Hi everyone, thank you. So intentionally, you could see that Dr. Hari was taking time, and as he correctly said, he was not giving answers correctly. So there's something called a flow that everybody likes. All examiners like a very good flow of answers. So maybe you know a lot about the topic, but the importance is what you say from your mouth. So instead of trying to say everything, say certain points that are very important to it and say it in a flow. Don't go up and down. And but what I suggest all of the candidates is after you read the question, take a moment, take at least 5 or 10 seconds, frame the answer in your head, because during the vignette you'll get an idea about what the examiner is trying to ask you, and there'll be certain things that they're looking for which are very obvious for you. So if you've read properly, which all of you have already, you just take a moment and try and think about what they're trying to ask out of you. If you do that, it'll always help you. Don't rush into the answers. Just take a moment and think and frame your answers. That is what we've said to the previous batches as well. If you frame your answers well, you miss not saying all the points. You don't have to know about all the trials. As long as you know the theme of what it needs to be done, you'll be fine. So yeah, stick to a mental framework as to how you're going to go about answers. Like there's certain things that you should know, like definitions, the definition of sepsis and septic shock. These things will come to you because you've read about. As far as clinical scenarios go, these are things that you've all read about, but you need to have a framework as to how you answer. If you dive into that framework, it'll be very easy. Apart from that, we'll meet you in the exams. I mean, and we'll give you feedback. Don't worry. Yeah. Thank you.
Dr. Tilak, do you want to add anything to this?
I just wanted to communicate two things. One, I would like to re-emphasize what Dr. Alisha said. There will be different vignettes. So even in one vignette you were not able to perform, please keep a cool mind. The next vignette will be totally different. Like how in this case, it went from sepsis and then it changed to post-cardiac arrest protocol. So even if you fumbled in one vignette, you can always score in the other vignette. So the questions are framed in such a way that it is to make you clear the exam. So make sure you don't lose your temper, answer calmly. That is one thing. And second thing, even if you're finding it difficult, just imagine that you are managing this patient in your duty and try to answer what you do and what your institute does. Sometimes that will also help. So you can say in our institute, we follow insulin infusion as per this protocol. You can actually mention it and it will be helpful also. Okay. So the mindset would be to clear you off. You just have to be confident and answer with a normal temper.
Just one more thing, like what Dr. Hariharan already told. If they're asking you about trials, it means two things. Either you have uttered a lot of trial names by mistake or in a panic or anxiety, or you have answered really well that they're not left with anything to ask you, so they're asking you trials. Usually in IDCCM exam, because it's a vignette based exam and there is a time allotted like 25 minutes for each case, they don't go asking you about trials. If they have to really ask you about a trial, it'll be already mentioned in the vignette as a question that name two trials probably related to ARDS, landmark trials like that. So you talked about Prosiva or you talked about the ArtsNet study. So like that, it will be already mentioned. Either you have finished your case early and then your teacher, your examiner wants to ask you some extra questions like for brownie points, So they ask you that, or while answering, you have muttered a trial's name so many times, either you have quoted that or something, and then they go into that trial. So don't mention anything extra. The questions will be very straightforward. There will be no pathophysiology questions, or there will be no questions on pathogenesis, how this happens, or explain that. The questions will be very, to the point questions, that what is, like we have asked over here, what will you counsel the family members, or what is the role of TTM management, just that much. You just tell what, like, to the point answers. Don't go on explaining. Don't quote trials until and unless you are asked, because in IDCCM they don't expect, if they ask you and you're able to tell, it definitely adds some more extra those marks for you. Okay, so stick to the question, make your answers crisp, organize and answer.
Okay, the last thing which I would want to add is, please read what you have already read. Please don't try to read from new books, new things, and because you'll be losing time on it. Try to read which will come for the cases. We've already shared it on the group. So read regarding those cases which you have already read again and again, so that you know how to frame your answer. So it'll be easier for you. All the best, everybody. We'll meet you in the mock exams. So mock 1 and mock 2. So you will get feedbacks of your mock 1 and mock 2. So you will be able to see how you're answering in the exam. If there are any questions, please post it in the chat box. We will answer your questions. We'll wait for another 5 minutes. If there are any questions, you can post it in the chat box, or we can end the webinar.
We'll end the webinar. I think let them put it in the WhatsApp group if anything is there. All of us are available in the WhatsApp group anyways.
Yeah, so please guys, if you have any questions, you can post it in the WhatsApp group, and all of us are there to answer your questions. All the best guys. We'll all meet you in the mock exam.